session. Our first topic will be by Dr. Manju or Pillai Madam. She's a glaucoma consultant in Arvind Madurai. She will be discussing the protocol for management of childhood glaucoma. What you, Madam?
So, good morning to all of you. And primary objective is to normalize and permanently control the intraocular pressure by preventing loss of visual acuity, preserving visual field and ocular integrity, and to stimulate the development of binocular stereoscopic vision. And here is a small video. And the incidence of childhood glaucoma is 2.29 per 1 lakh population and occurs in about 1 in 10,000 births.
Childhood glaucoma affects 1 in 15,000 live births. The Childhood Glaucoma Research Network, composed of clinicians and scientists in collaboration with the World Glaucoma Association, in July 2013, developed a new classification system for childhood glaucoma.
So this classification is in place for the past 20 years.
Childhood glaucoma is mainly classified primary childhood glaucoma and secondary childhood glaucoma. Primary childhood glaucoma is further classified into primary congenital glaucoma and juvenile open-angle glaucoma. Primary congenital glaucoma is subcategorized based on the age of onset as neonatal, infantile, and late. Secondary childhood glaucoma is classified into glaucoma associated with non-acquired ocular anomalies, glaucoma associated with non-acquired systemic anomalies, and glaucoma following cataract surgery. We have classified the protocol based on the age of the child, that is, for infants less than 1 year and for children more than 1 year. For infants less than 1 year of age, initially vision assessment is done. A detailed history, including the antenatal history, the birth history, postnatal history, family history, pedigree chart, and past medical and surgical history are noted. Intraocular pressure is checked by the eye care tonometer, and a preliminary examination is done by a torchlight or a portable slit lamp, followed by documenting a clinical photo. For children more than 1 year of age, vision assessment is done initially and can be classified as children with clear cornea and children with a cloudy cornea. In children with a clear cornea, refraction is done, followed by history documentation, whereas in children with a cloudy cornea, directly history documentation is done, as refraction cannot be performed in these cases. After taking history and the intraocular pressure measurement, the axial length is measured, followed by ocular examination by torchlight or a portable slit lamp or slit lamp examination depending on the child's cooperation. So how frequently should the axial length be checked? It has to be checked every 6 months for children less than 5 years of age and every year in children more than 5 years of age. How frequent should we check the intraocular pressure? The intraocular pressure has to be checked every visit as it plays a key role in deciding the management. Essential elements in a review case record include the visual acuity, refraction, intraocular pressure, ocular examination, and axial length measurement whenever necessary. For the required children, low vision assessment is done and any other investigations like B-scan or UVM are performed whenever necessary or whenever indicated. A final examination is then done by a senior glaucoma consultant and a pediatric ophthalmologist, and the management is done either medically or a planned examination under anesthesia is then done. Counseling is also done to explain the parents regarding the disease and the importance of medical management. And also, sibling counseling is emphasized. A detailed systemic examination is performed and a pediatric referral is also done if necessary. For children with amblyopia, a pediatric ophthalmologist consultation is done and patching is followed as advised. Low vision assessment is also done whenever required for certain children. For infants from 0 to 6 months who have visual potential of fixing and following light, torch light with color balls and running light are used. For infants who cannot fix the light, color balls and running lights are used for vision stimulation. For children with age more than 1 year, Vision stimulation is enhanced by picking object activities, and assessment is done using teller acuity, Lear grating, and hiding. If the child is special, then only Lear grating and hiding are used in the assessment. For children more than 5 years of age, hiding and Pelidopsin chart are used. The children are trained in a child-friendly environment to walk independently. The Vikas app is also used to understand the level of understanding of the child and also helps in assessing the child's ability and the areas in training. Digital magnifiers can be used to enhance the reading ability of the child. The recent developments are the smart vision glasses. This is a wearable device which works on artificial intelligence, machine vision, and machine learning and helps in facial recognition, provides walking assistance, reading assistance, and also to understand the surrounding things.
So that is about the clinical examination. In the surgical management, surgery is the mainstay of treatment, and the first chance of surgery is often the best chance. But glaucoma surgery in children is very challenging than adults. The angle surgeries that we do are either goniotomy or trabeculotomy. The challenges being distorted limbal anatomy, thin elastic sclera, and there is predisposes to a leakage around the tube when we do it because it's a ophthalmic eye. Distortion due to previous surgery is also a challenge. Aggressive healing and inflammatory response in children is more because of the thick tenons capsule. And anatomical fractures like thick tenons and fibroblasts lead to scarring. Post-op follow-up, there can be a lack of cooperation, and we need to even have long-term visual outcomes after the surgery, that is emmetropic correction and amblyopia management. So surgeries for childhood glaucoma that we do is initially we try trabeculotomy, or in advanced cases we try combined trabeculotomy plus trabeculectomy, and then we try tubes in refractory glaucomas, or even if the first surgery fails, when there is a limited long-term success, we do diode CPC. And sometimes if a visceration is required, if the child is big enough, we take the consent of the child if possible. Informed consent needs to be obtained for examination of surgery and general anesthesia. An ideal time to record an intraocular pressure is prior to the administration of an inhalational general anesthetic. Accurate measurement of IOP is the basic requirement for diagnosing and monitoring therapy of childhood glaucoma. And measuring the intraocular pressure is a challenging task in children. So preoperative considerations that we need to look for in healthy children, it's not very much, but children with chromosomal or metabolic disorders, there is an anesthetic challenge and there is a post-op follow-up that needs to be planned. Preoperative medications should be given very carefully because ocular cardiac reflex may be induced during an eye surgery which provoke dangerous bradycardias. This can be prevented by pre-medicating with anticholinergic agents. So the anesthetist needs to be informed in prior on what are the medications that we are using for the child, even if topically. The fasting guidelines, less than 6 months is 3 hours fasting. 6 to 36 months, it's 4 hours fasting, and more than 3 years, it's 8 hours fasting. And this is a very small video on how we do a trabeculotomy. We cut the conjunctiva, including the tenons, but we don't give an antimetabolite when it's a plain trabeculotomy. We cauterize the vessels and take a triangular flap. Identifying the correct anatomy is very important while doing a trabeculotomy because we now need to reflect the spiral flap till the limbus, and it's a distorted anatomy, so the Schrems canal is a little posterior. So as the textbooks has described, the blue meets the white, and that's where we need to keep the incision. The seepage of aqueous is enough to put in the trabeculotome. If there is a gush of aqueous, then we can be sure that we have entered the anterior chamber. So this is very important. Yes, then the aqueous has come out, and then identifying the correct part is important. So challenges in the post-op or post-operative urgent measures like suture removal or an anti-scarring agent like 5FU is difficult, and caregivers' commitment to post-op regimen is very important. The medications that can be absorbed through the pharyngeal mucosa via the nasolacrimal ducts are timolol or betoxolol. So this can cause bradycardia while giving GA. And carbonic anhydrase inhibitors, long time back, they were using half diamox as crushed tablets for the babies. This can give rise to metabolic acidosis and electrolyte abnormalities. So anesthetic agents that can affect on to the intraocular pressures are propofol can reduce by 30%, opioids minimal effect, atropine no effect, ketamine dose dependent increase in IOP. So what we use are sevoflurane, and intravenous anesthesia can be either propofol or ketamine. So ketamine is the second leg of choice for EUA, and the EUA set includes checking intraocular pressure, corneal diameter, refraction, anterior segment examination, gonioscopy, fundus evaluation, corneal thickness, B-scan, and UVM. Thank you.
Thank you, madam, for that enlightening talk. We will keep the discussion to the end.
Yeah, I'm leaving. Thank you.
So any questions anybody has regarding the childhood glaucoma?
So if you want to have an elaborate discussion on childhood glaucoma, please attend our conference in Madurai in December 12th and 13th. That will be the best.
Okay, ma'am. Thank you, ma'am.
We now request Dr. Manju R. Pillai ma'am to collect memento from Dr. Manju M.